Welcome to today's live event from Cleveland Clinic Broadcast. I want to thank over 800 healthcare providers registered for today's event from across the globe, representing over 80 countries. Please interact during the program via the chat box. We're very happy to make this interactive. We want this program to be as interactive as possible. We encourage you to use the chat box to send in your comments, questions during the broadcast. And then I'd like to acknowledge our industry sponsors. We'd like to thank our corporate sponsors for the generosity in providing educational grants for our 2025 series. We could not hold these CME offerings without our industry sponsors, and we are most grateful for the support from Cook Medical LLC, Janssen Biotech Incorporated, Medtronic, and Olympus Corporation of the Americas. And now it's my distinct honor to introduce the faculty. As mentioned, Dr. Walsh is the chair of Department of General Surgery, professor of surgery, Cleveland Clinic College of Medicine. I am the director of melanoma and cutaneous oncology surgery, also a professor of surgery at the Cleveland Clinic Learner College of Medicine. And really the honor is to introduce the participants, the excellent melanoma surgeons we have today, including Dr. Schindorf, who is a relatively new addition, completing her general surgery training at University of Colorado, and then doing a fellowship at University of Louisville in surgical oncology. Dr. Tafaro, Professor Tafaro, who's in the Department of Plastic Surgery, did his surgery training at Johns Hopkins, did some fellowship work at Johns Hopkins and surgical oncology at Memorial Sloan Kettering. And then Dr. Visioni, who's heading up the oncology, surgical oncology practice at Akron, completed his surgery training at Case Western Reserve University and fellowship training at Roswell Park Cancer Institute. And I thank all of them for being here. And Dr. Visioni is going to jump right in and talk about in-transit melanoma.
Yeah, thank you for such a lovely introduction. And yeah, I'll happily talk about an unfortunate disease process that's near and dear to my heart. Perfect. Thank you, Steve, for getting that going. So as Dr. Skitsky said, today I'm going to be doing a brief chat about the kind of considerations, multiple different considerations for the treatment of in-transit melanoma. I can go ahead, Steve. So I think obviously the first step is making sure we're all on the same page, kind of a little bit of a definition. So in-transit melanoma, kind of pretty simply, is kind of local regional metastases in kind of the dermis and subdermal lymphatic system. It can also be into the soft tissue, into the muscular system, and kind of even generally speaking, sometimes into the skeletal system, but that may have some different biology to them. So a lot of times when we see in-transit melanoma, it's truly more in that cutaneous and dermal tissues. This is synonymous, and I'm going to kind of use the term in-transit holistically, but it's synonymous with really microsatellite and satellite metastases, which are functionally, biologically, we would consider the same. Really, microsatellite is something you'd see on that primary pathology, and satellitosis or satellite metastases are just defined as a separate distance away. So under 2 centimeters for satellites and greater than 2 centimeters for in-transit. So if you'll beg my pardon, I'll just use that as a blanket statement, just saying in-transit melanoma. You can go ahead, Steve. So if you've treated melanoma for any amount of time, you've kind of seen these situations, I think. So this is exactly what we're talking about. Full disclosure here, these are actually Dr. Skitsky's patients. I trained with him too. So these are patients at Roswell Park. So these pictures have been around for a long time. But you see kind of some of the burden of this disease can be pretty significant. Go ahead, next. So, and that kind of portends, even though this is local regional metastases, this portends a more morbidity oftentimes. So you can see that within any lymph node staging, this is AJCC 8 staging, the presence of in-transit metastases really portends kind of a worse survival, worse prognosis. So it kind of brings you down all the way to stage, kind of within the group, stage C disease, so N1C, 2C, or 3C. So definitely has a higher risk disease burden. Next slide. And then that's kind of, by definition, when you combine it all together with primary melanomas, really all of these patients that we're talking about are going to be in these three subgroups. So obviously for truly metastatic disease, stage 4 disease, that's a separate burden, but they're often combined. We do see a lot of in-transit disease has systemic disease as well, synchronous systemic disease. But today, obviously, we want to focus a little bit more on pure in-transit disease. So these are going to be patients that are ultimately stage 3B, C, and D. Go ahead and go next slide. So kind of the patients who are at risk for developing this disease, we don't always have a great handle on it. Sometimes the statistics kind of are very broad. You can see incidence of anywhere from 3 to 15% of melanomas being what we would consider like lymphotropic or staying within like an in-transit disease. So this is a nice study that I thought I'd bring up from a great group of surgeons kind of around the country, the Sentinel Lymph Node Working Group, that kind of tried to look for some prognostic factors for who could potentially develop these in-transit metastases. Right, next slide. And in general, I think some of this information is probably self-explanatory. So Breslow thickness on a sliding scale is a higher risk factor. You can see with a hazard ratio that's marginally elevated. Age, very marginally elevated risk factor. Increasing age puts you at increasing risk. And we do see that in stage for stage melanoma. Older patients have higher risk of morbidity. A kind of primary lesion on the lower extremity versus the trunk. So we do see this in I think, clinical practice. Anecdotally, a lot of us would notice this too. Lower extremities do tend to be affected pretty significantly. That being said, we have, and I have seen it on chest wall and neck, upper extremities all over the place. But compared to other areas, the lower extremities affected pretty often. Increasing sentinel positive nodes, so having lymphatic disease already puts you at risk. Vascular invasion, and then weirdly enough, kind of from an uncertain reason, but probably biologically, having a melanoma arise from a pre-existing nevus. This last one seems to be protective for it. You can go to the next slide. So really kind of, I think what we really want to talk about today is kind of our management options or how we can approach these. So I'll spend a little extra time here, and then we could talk about some subsets and specifics. So I think local excision or local treatment by excision is kind of an important concept. It's really a very kind of useful tool. We use it very often, but it also kind of has to make biologic sense. So I didn't put any extra slides on this one because I think it's self-explanatory. If you can remove it, I think it's very reasonable to remove it. I think most of us would say that. That also kind of is in relationship to the time course of this disease. Sometimes it presents multiple years later. Sometimes it presents fairly rapidly after a wide local excision. So kind of having an understanding of the biology helps with your expectations for the effectiveness of a local excision. Obviously, the more disease interval, probably the more likely you're going to have good results from a local excision. This also is a slightly different disease process than, a primary melanoma, where our margin status for primary melanoma is based off Breslow depth don't necessarily apply here in this realm. So we really just want a negative margin excision, ideally. There's all sorts of debate about whether or not we actually chase a positive margin on these patients, whether they get adjuvant treatment, sometimes radiation. But suffice to say, local excision with a negative margin would be kind of ideal in certain situations. I'll spend a little more time on intralesional therapy, so I'll kind of skip that for a hot second, but just to kind of flesh it out, there's TVEC, which please, I beg you not to ask me to pronounce the whole name of it. So TVEC is our herpes virus, genetically engineered herpes virus to attack tumor directly, but then also potentially have immunologic spread to other distant sites. That's kind of FDA approved and in most common usage. There still is utilization of IL-2 locally as kind of an intralesional therapy. It's a little less common these days. Classically, BCG and something called PV10 or rose bengal has also been used and studied. They've kind of fallen off as much. They're not as readily available. So TVEC is going to be your pretty predominant intralesional therapy. Radiation definitely still plays a role in certain instances, and the idea, which I hear still, that melanoma is not radiosensitive isn't totally true. I think it's just a matter of how we use it and what burden of disease we can expect a result from. So really, truly big, bulky melanoma probably isn't going to respond incredibly well to radiation. Maybe microscopic disease or minimal residual disease has maybe the most benefit there. Regional therapies, so isolated limb infusion, ILI, or isolated limb perfusion, ILP, which I'll kind of use a little bit interchangeably today. They are treatments from the 1950s is when they originated, and the updated versions from the 1990s. So they're classic treatments, but they still have a strong role in the management of in-transit disease. And we'll actually, in one of our case presentations, I think, go over that. So definitely the landscape has changed, but all the tools we have to bear, even the ones from, 60 years ago or more, are still really highly utilized. And then obviously systemic therapies with targeted therapy and checkpoint inhibitors, that has kind of revolutionized melanoma care, and it has in this realm too as well. So we'll talk a little bit about that too. Okay, so you can go to the next slide. So this is a kind of a landmark study for the TVEC injections. So it's a final analysis. I kind of wanted to bring up this study because I think it highlights a little bit of what we see in clinical practice with TVEC injections. You can go to the next slide. So this is patients who were injected with TVEC who had anywhere from stage 3B disease to stage M1B or C disease. So a quick refresher here. Stage 3 AB and or stage 3B CD we talked about. M1A is distant dermal metastases. M1B and C are lung and more systemic metastases and CSF metastases. So BC are much more significant systemic disease. So M1A is also non-regional lymph nodes as well. So these patients are kind of categorized as the complete subset here. So the upper left box is kind of all the patients of this, and this is in comparison to GM-CSF, kind of granulocyte stimulating factors, which is actually part of TVEC as well. So you see TVEC does have some increased response of overall survival. But if you break it down, the patients with truly more localized stage 3 disease seem to actually have that most robust response. The lesions that we inject do seem to respond more than kind of surrounding lesions. So you can't necessarily expect TVEC to treat lung metastases as well. And that's borne out by kind of the lower left corner. So a little bit more metastatic disease, but kind of the same maybe biology, more dermal lymphatic metastases versus true lung met systemic disease. You see the overall survival tends actually not to be very well improved in those patients. So how we use TVEC is really important, and what you can expect from it is really important. If you have hundreds of lesions on a leg and you can't inject them all, you probably aren't going to see as much of a response as you need to with TVEC, although it still is a tool. We can go to the next slide. So this is actually some data from isolated limb infusions, and like I said, still useful in clinical practice. Kind of briefly, kind of the way we, I think, approach this is when we have a objective response rate or overall response rate, and that's considering complete responses as well as partial responses. We tend to tell patients it's around 2/3, around 64% in this study. Can go up to about 70% depending on the studies you use. When you add stable disease to that kind of category, it can be as high as almost 75-80% of patients can have some benefit of doing this treatment. And it's kind of a reminder, this is using melphalan chemotherapy to kind of infuse the leg with heat addition as kind of an immunogenic stimuli. So it's a fairly straightforward technical procedure, but it's nuanced enough that it's not done, quite frankly, at a lot of centers. The complete response rate, the time to it, 28% of patients had infield progression at 3 years. So generally speaking, it can be pretty durable too. So if you do respond, if you have a complete response, that complete response can be prolonged, which is pretty cool about this treatment. Let's go to the next slide. So this is kind of one of our more famous studies, not ours, I didn't do it, but it's a study of pembrolizumab, obviously our game-changing medication for melanoma in stage 3 disease. And it's important to note that in this trial, this is the quote from the trial, but it's stage 3B and C disease. This is based off AJCC7, but that it's excluding patients with in-transit disease. So how well systemic therapy, particularly systemic immunotherapy, works in this particular subset of patients is a little unknown. And I think we've all treated patients where we've seen really robust responses, but maybe not the percentage of patients that you would see actually who have more systemic disease or the response rates of that. So it could be a little bit more of a challenge treating this with just immunotherapy alone. Go to the next slide. I apologize to anybody if I'm talking very fast. We have limited time, and I like this topic, so I'm just doing a lot. But please ask questions if things come up, if I'm not being clear enough. So kind of continuing on. So the interesting concepts now are talking about combining modalities, I think. So in this particular study, this was actually including James P. Allison, obviously, who's won a Nobel Prize. So I trust that he does good work. It's a really good study, and it's looking at a lot of biologic factors, but also kind of clinical outcomes. And this is for performing an isolated limb infusion in conjunction with CTLA-4 blockade or ipilimumab. And in this particular study, the overall response rates go, maybe from that mid 60%, go all the way up to 85%, which is pretty cool. But even more importantly, the complete response rate really, doubles. It really was quite high. So you do see a lot more complete responders. And once again, that complete response rate can be quite durable. So in this study, at 3 years, the median progression-free survival wasn't reached on those patients. So I think we would hesitate to say we're curing people, but we can definitely get some really prolonged, durable responses. So combining therapies becomes pretty interesting and novel when we look at it this way. Go to the next slide. Interestingly enough, on the flip side here, this is a combination of T-VEC and pembrolizumab that was done. A very nice study that came out that more or less shows for all comers, T-VEC with the addition of pembrolizumab probably doesn't affect the biology too much. It probably doesn't change our progression-free survival. I think what's interesting here is these are patients who are more or less treatment naive, we'll say, and they were started either on pembrolizumab and a placebo versus T-VEC and pembrolizumab. I think anecdotally or with some other kind of data, we probably see that if you look at patients who are failing pembrolizumab, the addition of T-VEC may change that balance. So we still have some role for the combination here, but at least from a de novo patient population, it doesn't seem that just doing them both together truly matters. So we have to kind of suss out and to identify those patients a little bit better, but definitely we've seen some role in certain patient populations. Go to the next slide. So I hope I'm not going over time or anything. I've tried to kind of cover a bunch of different topics. But in essence, this is a really challenging disease. So like I said earlier, the incidence is kind of a little bit all over the place in studies. But classically speaking, it's the minority of these melanoma patients. But when you have them, they can kind of take up a lot of resources because they are quite challenging. So there's a considerable difference in these patients in terms of the time to presentation, in terms of the amount and burden of disease. Some patients with very minimal, one in transit metastases 2 years after a wide local excision is very different than 100, 3 months after a wide local excision. They do portend a worse prognosis, but we do have some treatments that actually can have very good outcomes. And there's a relatively high rate of systemic metastases to these patients. So because of that, thinking about that as a systemic disease, depending on their biologic features, is important, I think. And I think, as we're probably going to hear a lot in any kind of cancer care in any context, really these treatment decisions, how we approach these patients really is a multidisciplinary team approach, which I think we really enjoy doing through our melanoma department. And it's really individualized. So as you kind of bring to bear all of our different treatment options that we have, which we do have a bunch, kind of individualizing that to the patient as well as to kind of their course of disease. So really that roundtable discussion, it becomes huge. I think I'll pause there for any questions or turn the floor over to my colleagues.
Yeah, we'll go on to the next topic, and we'll have any questions, please put them in the chat box, and we'll be happy to talk about them. But right now, we're going to have Dr. Tafaro present on head and neck melanomas. Dr. Tafaro.
I'd like to thank the organizers of this meeting for inviting me to be part of it. It's quite an honor. So I combined my training as a board-certified plastic surgeon and a fellowship-trained surgical oncologist at Sloan Kettering to bring those two trainings together for the unique problem of head and neck melanoma. Next slide, please. Next slide. Melanoma, sixth most common cancer in the U.S., fifth most common in men, seventh most common in women. The interesting thing, it's the women, 25 to 29, it is the most common cancer for women in that age, and the second most common cancer for women, 30 to 34. There's approximately 68,000 cases per year and 8,700 deaths. Melanoma accounts for the third highest number of deaths across all cancers. Next slide, please. So about 25 to 30% of all melanomas are found in the head and neck, but they may be the most complicated management. Melanoma of your mid-cheek is a lot different than a melanoma on your back or your thigh. Common locations, face, 40 to 60% of these will be found in the face, 14 to 40% on the scalp, neck 20 to 29, and finally the ear, 8 to 11%. Very complicated on the ear though, because of the small amount of tissue you have for the reconstruction and resection. Next slide, please. So this is the basic principle of oncologic surgery. Have past slides reviewed. Be sure of the tumor thickness, level of invasion, and margins. This is a common problem today when many of our patients come with shave biopsies and positive deep margins. Make your management plans before you go to the operating room. Be sure of what you're going to do as far as your reconstruction effort. Melanoma in the head and neck and face, your reconstruction is going to be the first thing the patient asks about. And then, of course, always have a fallback plan. Next slide, please. Unique problems of the head and neck. The patient must be assured that we can resect the melanoma and reconstruct the surgical defect and return them to a normal life, meaning sitting at the dining room table with friends and family, or going out in public or returning to their job. The management of the primary tumor will require reconstruction that is evaluated by the public, unlike a melanoma of the back or leg or even the chest wall. Careful planning of incisions and preservation of function and future surgery should be built into your resection, and you'll see some evidence of that. The sentinel node process may be more complicated in the head and neck due to the anatomy and the proximity of the primary site to the nodal basin in question. Next slide, please. So here we go. Here's a typical problem. This on the left appears to be a young female with a melanoma just at her orbital rim on the right side. Well, if we go with a 1 to 2 centimeter resection, are we going to resect her canthal area and upper and lower eyelid? Probably not. So just like if we're operating at the porta hepatis or some other vital area, we get the margin that we can, obviously, with the idea that this would severely debilitate the patient if we take both eyelids on a resection. If we look at the older gentleman on the right side there, his melanoma is right at the lateral commissure of his lip. Now he has more skin laxity, and you see I've outlined some potential incision lines we would need to close this defect, and we'll show you some clinical examples of this. Next slide, please. So here we go with a lady with an invasive melanoma right in the midpoint of her cheek. White female, and you can see those age lines already, and we're going to use those to our advantage. There's our resection margin, a rather generous resection, and I've outlined her labial mental groove, nasolabial groove, and next slide, please. And you can see the size of the incision to mobilize tissue into the area without tension. The idea is that if you make a smaller incision and create tension, the flap is going to die down. The important question on the right is looking at her in animation. Our incision lines fall directly in her nasolabial groove, and she animates without any disability to her facial nerve function. Remember, the dissection has to stay above the innervation of the mimetic muscles, otherwise you're going to disrupt facial nerve function. Next slide, please. So we talked about the problem of sentinel node biopsy in the head and neck. A lymphoscintigraphy is a must in the head and neck, and the addition of blue dye can be helpful, whether you want to use ICG, lymphozurin, or methylene blue would be your choice, but it's always an advantage to use both, particularly in the head and neck. If you try to guess where the sentinel node will be, you're going to be wrong 30 to 50% of the time. Intraparotid nodes are very common, and they'll require some experience or comfort operating in and around the parotid gland and the facial nerve. Plan your incisions carefully so that reconstruction and possible future neck dissections and parotidectomies are not compromised. It's quite an important point. Next. So this is a beautiful example of a lymphozurin injected for identification. So this is a thick melanoma on the scalp. This lady had a melanoma about 6 millimeters thick. And we can see on the right a blue-green trail going through the deep fascia just behind her ear. To orient you, at 12 o'clock is the posterior aspect of her pinna, and we've made an incision right over her mastoid. Now, this blue-green dye seems to disappear, but you can see there an incision through that fascia. Next slide, please. And there you go. Right there in the middle of our field is a very small lymph node stained blue. The blue dye has helped us follow it to that area, deep to that thick fascia, which you would never see unless you were guided to make that incision. We use our lymphoscintigraphy and the blue dye as a great adjunct in head and neck melanoma management. Next slide, please. So here's another problem of the head and neck: the proximity of our sentinel node to the primary injection site. You can see in the preauricular area there, right over his parotid gland, our circle of our marked resection on this 2.2 millimeter thick melanoma. Those 3 X's are the sentinel nodes that lit up with lymphoscintigraphy. If you follow my incision down in the preauricular area around the lobule of the ear into the neck, that's what I talked about, planning our incisions so that we can best approach our sentinel node biopsy and not burn any bridges. Now, I've taken that incision all the way down into the neck to mobilize the loose skin of the lower portion of the neck to close our defect. On the right-hand side, you see a small lymph node with some blue pigment in it. Again, the blue dye has helped us as an adjunct to our lymphoscintigraphy. Now we're going to elevate that entire flap at the level of the parotid fascia and into the neck. Next slide, please. And you can see how through that one group of incisions, we've resected the primary melanoma, carried the dissection into the neck, mobilized the entire lateral neck and face into the defect to close with like skin, meaning color, thickness, and contour match his pre-morbid problem, his situation. Next slide, please. So when we think about reconstruction of these defects, there's an actual reconstructive ladder, we call it. It goes from most simple to complex. Most simple would be healing by secondary intention. For smaller defects, that's perfectly acceptable, and many physicians would do that. And the most complex would be distant flaps, taking tissue from somewhere else and moving it into the defect. Next slide, please. So to decide what you're going to do, you really need a careful wound analysis. Where is it? What's the location? Is it at the lateral canthus of my eye, or is it on my neck or posterior neck or scalp? There's a big difference between those two sites. How big is it? On the scalp, excision sites size bigger than 2 to 3 centimeters are going to be difficult to close with primary closure. And what is missing? Is it skin, subcutaneous tissue, muscle, cartilage, bone? All those things have to be planned before you go to the operating room. And you should have a good idea of what you're going to do to replace missing parts. Next slide, please. So we use this concept that the face is divided by ridges and valleys into slightly convex and slightly concave surfaces whose contour is determined by the underlying hard and soft tissue. Next slide, please. And you can see these lines are clearly visible on an older patient, but on many of my younger patients, as I saw a lady today who's 34 years old, who had a melanoma on the lateral cheek, she has none of these lines. But we know that she's going to develop them over time, and we manage these reconstructions by utilizing these natural lines that occur on everyone's face as we age. Next slide, please. So you see how complex the aesthetic units are on the nose. There's 7 or 8 different sites: sidewall, dorsum, nasal tip, soft triangle. And we have to take this into account if we're going to resect the malignancy there and reconstruct it. Next slide, please. The central face is seen in primary gaze, and the contralateral normal subunits are available for critical comparison, meaning on the lateral portion of the face, that's less obvious. The lateral neck, the preauricular area. You can't really compare it to the other side, so you don't really get an idea of what's going on. But in the central face, you're going to see and compare one side to the other. So we really have to recapitulate what's on the other side. Next slide, please. So skin grafts and flaps. Skin grafts are recommended to resurface well-vascularized superficial defects when only skin and a small amount of tissue are missing. So if you resect a melanoma on the mid-cheek with a significant subcutaneous fat and go down to muscle, that defect is going to be difficult to reconstruct with just a skin graft. Flaps are best to replace convex facial surfaces. Grafts are best to replace planar or concave recipient sites. Postoperatively, skin grafts are typically shiny, atrophic, and hypopigmented. And you'll see some examples of this. Next slide. So here it is. Somebody missed the concepts we've been speaking about as far as aesthetic units and what a skin graft is going to look like. You can see that the sidewall is violated and the skin graft is carried actually onto the cheek. Now we fixed this by making an incision along the sidewall, excising that skin graft and moving the cheek into the defect. And I offered him a different type of reconstruction for the nasal sidewall, which the patient did not want. But you'll see what we could offer patients with this situation. But this is what happens when those aesthetic units and principles are violated. Next slide, please. So here's a perfect example of a full thickness skin graft in a lady who had an extensive melanoma in situ. So she's a white patient in her late 70s. There she is with resection, and we harvested a full thickness skin graft from her neck because it's going to have like color. This is a concave surface with a thin resection. Next slide, please. On the left, you see it at just 2 weeks post-op, some crusting at the margins. The skin graft is fully taken. If you look at it 4 months post-op, I would say to the most average observer, that's almost imperceptible. Full thickness skin graft in a Caucasian patient on a convex surface like that is most part of the time going to do well. Next slide. Here is a very thick melanoma, a large resection margin, and we're not going to be able to move hair-bearing skin into that area. Next slide. You see the size of that defect. We've left pericranium so that we could put a split thickness skin graft on that area. The other option would be a free tissue transfer from her anterolateral thigh, her radial forearm, much more complicated. This is an older, ill patient. Skin graft is the answer for this large defect, and it will not be hair-bearing. Next slide. For patients who are concerned about hair-bearing skin, here we go. We have to put a tissue expander. Now, none of my adult patients, actually, in 27 years, I've only had one adult patient opt for the Mickey Mouse look. We use this in children, get away with it, but that's a way of moving hair-bearing skin into a large scalp defect. Next slide, please. So local random pattern flaps. These are based on a random subdermal plexus of vessels. It's usually good color and thickness match for the recipient bed because it's local tissue. We're limited by the size of the wound and the arc of rotation. Next slide, please. So here we go. Perfect example, lateral neck. You can see the 2 sentinel nodes marked on the patient's lateral cheek. I'm going to utilize that one incision, take out this melanoma, do a resection for the primary, and access those 2 sentinel nodes through this incision. Next slide. And you can see how we achieve that. Long incision in the neck, undermine onto the cheek, take out the sentinel nodes, and reconstruct all with a random pattern flap, utilizing the loose skin in the lower neck, moving it into the defect. Next slide, please. Random pattern flap. Here you see a relatively young patient with a melanoma on the nasal sidewall and the cheek, and you can see his nasolabial groove. Next slide, please. We've injected our blue dye to identify our sentinel node. And if you look at that, I've outlined our incision line along his nasolabial groove. and along the cheek-lid junction. Next slide. It's our resection, and we're going to move the cheek and the lid junction skin into that tissue. Next slide, please. Here's a bird's eye view of our flap elevated. It's got to be quite passive, otherwise the tension on the flap is going to pull it away from our inset. Next slide. And there he is. Now I violated his sidewall and cheek. Down the line, I could batten that down and improve our nasal sidewall, but he did not want any other surgery. And you can see I've marked out our sentinel lymph nodes in his left neck there. So one operation, resect, reconstruct, and sentinel nodes in one operation. Next slide, please. So here's a melanoma on the temporal area. And I want you to look at that small mole right in front of his tragus there and how we move that. Next slide. There's our defect. Next slide. So we just flipped it so you could compare. So that small mole is now above his ear, and you can see the size of the incision it took to get that closed. We had to carry it out in a natural skin crease at the lateral canthus, and we're going to mobilize all that skin up and into the defect and close everything primarily with like skin. Next slide, please. Axial pattern flaps is based on the concept of specific vascular territories based on direct cutaneous vascular pedicles. These are a little bit more complicated and allows for a wider arc of rotation and use of tissue outside the zone of injury. Often we have similar properties of skin thickness as the recipient area and like contours on the skin. Next slide. So the classic is a paramedian forehead flap. I've marked out this patient and we've marked out all her subunits on her nose. We're going to flip this over. Next slide. Same patient, but I'm going to take a axial pattern flap based on her supratrochlear artery with non-hair-bearing forehead skin. This is ideal for restructuring a nose. Next slide. So we've turned it down with the pedicle intact. We do not worry about the forehead defect, and I'll show you what happens to that. We let that heal by secondary intention. On a light-skinned patient, that's a convex surface that's going to heal with virtually invisible scar over time. So now we have vascularized tissue on the sidewall and nasal dorsum. Next slide. There it is, matured at about 3 weeks. At about 17 to 21 days, we test the viability of this by putting a rubber band around the pedicle and see if we blanch. As long as it's attached to the pedicle, I can lift this flap up and thin it, thin it, thin it. Once we cut the pedicle, we're destined to inset it, and we can't do any more manipulation with our flap. Next slide. So here's a lady who had a defect, bad melanoma, right on the tip of her nose. You can see how we harvest the paramedian forehead flap, close that up primarily, and you can see on the lower right, that's about 6 months out. I defy anybody to say what she's had done, period. Next slide, please. So here's a violation. You can see what's happening is this skin graft, as it contracts, it's distorted the lip, distorted the ala. We violated the cheek and lateral nasal sidewall. And you can see on the left side, the aesthetic units that we're going to utilize to reconstruct this. Next slide. So we have to recapitulate the defect, take out skin graft, undermine everything so that we can mobilize the skin. Next slide. Cheek was reconstructed with cheek. You can see that defect is gone. She's got a paramedian forehead flap reconstructed in the nasal sidewall and ala. Next slide, please. And there it is with the pedicle maturing. Next slide, please. So this is a little bit more complex. This lady, you can see on her left nostril, she's missing a full thickness defect, meaning nasal mucosa, submucosa cartilage, and skin. So we have to reconstruct both the inner and outer, create lining. We take a template from her normal side. Next slide. On the forehead, we create the lining and outer shell. Next slide. Inset, next slide. And here she is 6 months post-op. Now we've narrowed her nasal passage there. I offered to thin it out, but you can see the forehead is healed beautifully. At the worm's eye view, you get a sense of how it's narrowed. She did not want any more surgery, but obviously she's very happy with the result. Next slide, please. There's a mature nasal parent median forehead flap in a very light-skinned white female. The forehead is never worried about. Next slide. Lip, common sight. This patient had a amelanotic melanoma of the lower lip. We do a wedge resection of the lower lip in a W fashion. You'll see what happens to that W. Reconstructed from the upper lip with the labial artery. Next slide. The sentinel nodes are marked out. There it is, our resection. That W will become a V, and I'll show that to you again. Next slide, please. We turn the upper lip down into the defect. He gets some shortening of his lip, but very functional. Next slide, please. There's a little bit better view of that. Again, the W resection, we turn that W into a V. Otherwise, we'd be carrying that resection all the way to the inferior border of the mandible. Next slide, please. Upper lip turned into the lower lip. The W becomes a V. Next slide. And there he is. Next slide, please. So management head and neck melanoma is particularly difficult due to functional and aesthetic considerations in both the resection and reconstruction. A thorough knowledge of the oncologic management of the disease and functional and aesthetic reconstruction is essential to our success in treating these patients. Next slide. Thank you.
Truly excellent, Dr. Tafaro. But to stay on time, I'm going to have Dr. Schindorf give her presentation. Then we'll take some questions and have a little bit of discussion. Dr. Schindorf.
Perfect. I am going to try to share my screen with you all. Are you guys good? Can you see my slides?
Yes.
Oh, I'd probably put you guys over there. There you go. All right. So good evening. I want to thank everybody for the opportunity to present tonight, and I'll be presenting on the considerations we all have to take when managing patients with melanoma who also are immunosuppressed. Forewarning, I'm a surgeon, as we all are, all the panelists, but I am not a medical oncologist, although I'll be touching base on a few medical oncology topics. So, in order to lay the groundwork for the role that immunosuppression plays in the treatment of melanoma, in my mind, we have to first step back to look at the history of melanoma treatments, which Dr. Visioni mentioned some of them, and some of these basic science topics. So first and foremost, as mentioned before, and as many of you know, the treatment approach to melanoma has dramatically changed over the course of the last 2 decades, with great advances in improved overall survival and disease-free survival rates. And this is in large part due to the advent of immunotherapy treatments. The first immunotherapy treatment, which was ipilimumab, was approved by the FDA in 2011 to treat metastatic melanoma. And in today's world, ipilimumab, as well as many other newer immunotherapy agents, have become much more commonplace in both melanoma and other disease sites, and their indications for use have exponentially expanded. So in melanoma, the indications, one of the most common indications for use is stage 3 disease. There are some exceptions to this, including some small volume stage 3A or those occult positive sentinel lymph node with low volume disease. Immunotherapy can sometimes be admitted. Other studies have demonstrated that there is an improved disease-free survival in those high-risk stage 2, which includes the stage 2B, stage 2C patients. And this was noted in the Keynote 716 trial. And I've put these references in the corner for you all. And now, newer advances and more recent studies have investigated the role of neoadjuvant immunotherapy in these clinical stage 3 patients. So those palpable lymph nodes that you feel on exam. And these studies include the SWOG 1801 study, which 3 doses of neoadjuvant immunotherapy consisting of pembrolizumab was administered, followed by surgical resection of the primary site as well as the lymph nodes. And then the patients were completed their adjuvant immunotherapy for a total of a year of immunotherapy. The other trials that are notable are the Prado and Nadina trials, and these have demonstrated good results with 2 cycles of immunotherapy with ipi and nivolumab, followed by surgical resection of the primary and a targeted lymph node dissection. And the adjuvant therapy plan is then dictated based on the pathologic response of the nodal disease to that neoadjuvant immunotherapy. So taking one more step backwards, how does the immunotherapy work, and how does this play a role in the immunosuppressed population? So looking at the immune system, specifically the T cells, which ultimately is the crux of immunotherapy, the T cell's job is to surveil the body for abnormal cells or foreign cells and antigens. They perform this through the T cell receptor MHC interaction, as noted by this yellow rectangle. The antigen presenting cell, or the tumor cell, will then present the antigen on the cell surface via the MHC. And if the antigen is presented to the T cell, is considered normal or self by the T cell, then the T cell moves on and continues its surveillance. However, if the antigen that's presented to this T cell is identified as foreign or abnormal, as it is in cancer, the T cell will initiate a cascade of events that will eventually lead to the death of this presenting cell or tumor cell. And as with every cascade of events in the body, there needs to be a shutoff system before it goes too far. This negative feedback loop is triggered by another interaction of cell surface receptors on the T cell and the antigen presenting cell. These receptors include the PD-1 and CTLA-4 receptors and their associated ligands. And the balance between on and off typically occurs normally throughout the body all the time, except when it doesn't. And that's demonstrated by autoimmune diseases. These are examples of when the negative feedback loop isn't perfect and the T cells recognize the self cells as foreign or dangerous. In cancer, on the other hand, including melanoma, the tumor cells have identified this shutoff pathway and have exploited it. Therefore, they express the receptors as a way to evade these T cells, or to evade the T cell death signals. Immunotherapy treatments, including the anti-PD-1 and anti-CTLA-4, such as pembrolizumab and ipilimumab, block the interaction of these negative feedback loops, essentially taking the brakes off of the immune system. Now, ideally allowing the T cells to recognize and kill the tumor cells. However, immunotherapy isn't selective to only the T cells that recognize tumor cells. The immunotherapy agents cut the brakes on all the T cells, which, as you can imagine, can tip the scales to the other direction, as we mentioned, such as autoimmune disorders. And that's evident by the most common adverse effects from these immunotherapies are immune-related adverse effects, such as autoimmune pneumonitis, colitis, hepatitis, really any autoimmune disorder that can affect any and all organs. Most of these side effects can be managed with stopping the immunotherapy agent and prescribing steroids. And those patients with pre-existing autoimmune disorders are, by the NCCN, recommended to have this considered when discussing with their physicians about immunotherapy. So at first glance, it's interesting, according to the drug insert packet, that there are no true hard indications for administering these immunotherapy drugs. There are warnings regarding the immune-mediated adverse reactions like we just discussed. So if that is true, then what do you do when a patient with an autoimmune disorder presents with an advanced melanoma? I would say that most probably consider this a relative contraindication, depending on the type and the severity of the autoimmune disorder. That goes back to that all these treatments and interventions that we do is somewhat dependent upon an informed risk-benefit conversation with the patient, because somebody with mild rheumatoid arthritis may be having a very different conversation than somebody who has severe ulcerative colitis. And then what about those patients with a history of allogeneic transplants? Again, somewhat of a spectrum of a problem. A heart or a liver transplant is different than a patient who has had a kidney transplant. And so, you know, with a patient who has a kidney transplant, they have the backup of hemodialysis if their transplant is rejected. Although that's a large burden on the patients and not ideal, but those patients with heart or lung or liver transplants may not have that option. So at what point do you risk the transplant rejection versus the progression of melanoma? And that becomes a much stickier situation. And after looking through the literature, there really isn't a whole lot of published literature regarding these guidelines for these difficult situations. Although as immunotherapy becomes more commonplace, I think it will become a more encountered problem. So it does become worthwhile to start exploring other therapies for melanoma outside of immunotherapy. These can include the BRAF/MEK inhibitors, although these are dependent upon if the patient has the BRAF mutation demonstrated by their tumor. Other things that we have mentioned this evening is radiation. Adjuvant radiation can be used for high-risk resected regional disease, and it can decrease the lymph node basin recurrence, but does not affect their overall survival or relapse free survival. The indications for radiation therapy include extracapsular extension of positive sentinel lymph nodes in the cervical or axillary lymph node basins. If you have 2 or more positive nodes, it's greater than 3 if it's in the inguinal lymph node basin. And then also based on size. So if the tumor is involved in the lymph node greater than 3 centimeters, for the axillary or cervical lymph nodes, it is an indication. For the inguinal lymph nodes, it's greater than 4. And you can also, as Dr. Visioni mentioned earlier, use radiation as a definitive or palliative option for the unresectable satellite or in-transit disease. And then finally, for some of these patients who may not be a great candidate for immunotherapy or maybe BRAF mutant, maybe that observation is the best option for them until they recur. So that's just a brief overview. And does anybody have any questions? I'll stop sharing.
I think that was perfect, Dr. Schindorf. Thank you. I think we're in a bit of a time crunch. There was one question from the audience by Berkram Paul asking Dr. Tafaro how he would manage a melanoma of the upper eyelid. I think you gave a good example of that with the full thickness skin graft, but maybe you can just give a quick minute to discuss how you would do that.
So the management would be determined by the thickness of the primary lesion, right? So I would often take some, because the skin is so thin, I would take some of the orbicularis muscle as the deep margin, and in older patients particularly, you can close that up primarily. If it's a relatively small defect on the upper lid, you can repair it with a skin graft from the opposite side, the upper lid of the right side, if your melanoma is on the left side. It looks beautiful and it works out really well. If the lash line and the edge of the lid is involved, then you're going to have to consider how you're going to get the canthal tendon released to close up that defect. So if it's relatively small, meaning just the skin above the lash line, A full thickness skin graft from the opposite lid is always the answer. Take the a piece of bicularis as your deep margin.
Okay, so we're kind of on a time crunch, so we're going to go over the case studies. But before we do that, one more question for you, Dr. Tafaro. Quick minute response. MSLT2, multi-center selective lumpectomy trial, published in 2017, showed that if you have a positive sentinel node, axillary groin, we do nodal observation. That's the law of the land. For head and neck, do you think that applies, or how do you view that?
I think it does apply, and with the immunotherapies and targeted therapies, it's changed what I do markedly. I mean, 25 years ago, 27 years ago, I didn't have very much to offer these stage 3 patients, right? So we do a basin dissection, knowing that 30% of those patients are probably cured just by the operation alone. But we could avoid. Now, in the head and neck, I'm not so concerned about lymphedema and those other problems that we'll see in the groin, particularly in an older patient who may be heavy. So I do follow the MSLT2 trial protocols, and I do the sentinel node, and that may be therapeutic, may be diagnostic, but those patients are well treated with the immunotherapies and targeted therapies.
Okay.
So, Joe, can I ask a quick question? This is Matt Walsh. I really enjoyed all the talks. I have a question for Anthony. I can see a lot of providers working in this space, so to speak, and I'm curious as to what do you think the most common problem you have seen over your experience that you can give as a pearl?
So I see quite often people are forced to do or seem to do the wrong operation, meaning cut margins aren't what they should be, or avoid certain nodal beds because of they may be not so familiar with oncologic surgery of the head and neck. I've seen that. And the second thing is all the principles I showed there on the reconstruction and what to use where are often substituted by healing by secondary intention or a skin graft on everything. You can see I showed examples of distortion of the nose. I could show you on the eyelids. And so a skin graft, yes, will close the defect, which would be okay on the arm, the back, the leg. But in the head and neck, we need a violin, not a log. And it's a little bit more a measured response we need. And so I see people do incomplete operation because of they don't have enough knowledge of management of head and neck oncologic surgery. And they might opt just to put a skin graft on something that needs something else.
Good points. That's why I stay below the clavicles. Dr. Visioni, do you want to jump into your case and maybe like literally just try to crunch it down into like 3 to 4 minutes?
I can do that. Absolutely.
Okay.
So I think this will hopefully highlight a little bit of what I was referring to with the multidisciplinary approach and complexity of these patients. So this is our patient DL. She presented with this on her left fourth toe, pretty significant melanotic lesion. We can go to the next slide. So a biopsy was done. Obviously, this confirmed it to be melanoma. It was actually kind of piecemeal biopsied, so it didn't have a good depth, but even just based off it being probably a subungual distal phalanx melanoma. You can go to the next slide. She underwent a left fourth toe amputation with a sentinel lymph node biopsy. So her maximal Breslow depth on her final pathology was 15 millimeters with present ulceration, so a T4B lesion. With no disease in the regional sentinel lymph node. So her overall stage was a stage 2C to begin with. We can go ahead. At that time, when she had this done, there was no real adjuvant therapy in the situation. We can advance the slide. So she was placed on surveillance. She had scans that really didn't show any disease. Some significant medical history occurred over this time, and for her rheumatoid arthritis, she did need further treatment. You can go ahead. And so this is 4 years after her treatment. She developed this lesion of her lower leg, which she thought was a bruise. You can advance. So obviously a pretty far disease-free interval, but this did appear to be in-transit melanoma with staging revealing no subsequent disease, or I'm sorry, no distant disease. Regarding her rheumatoid arthritis, she was switched to a different rheumatoid drug, and she was started on dual agent immunotherapy with nivolumab and relatinib. Go ahead. So this actually turned out to be a little bit of disease progression, but then she did start this therapy, and she had kind of a mixed response. So certain lesions on her leg, which developed, regressed. Other ones kind of seemed a little bit more pronounced. We can go to the next slide. So the addition of TVEC was added. So she stayed on her nivolumab single agent. She had progression at that point in time, and so then she had TVEC. So now we're about 5 years out from her original diagnosis. This is kind of the disease burden, and this is the only disease burden she had. She did TVEC for a couple of months with then progression of disease. We can go ahead. So then we performed an isolated limb infusion with keeping her on her single agent immunotherapy that she was tolerating quite well. So this is about 6 months. This picture is about 6 months after her isolated limb infusion. Hopefully shows up pretty well. I want you to kind of appreciate, she's got vitiligo around all of her melanoma deposits. So it's kind of hard to see on the lower leg, but if you look up a little higher around her knee, you can see like little hypopigmented areas. Her clinical exam went from being nodular disease to really flat disease. Her PET scan showed a very good response. And so she kind of had a very clinically good response that was fairly durable. And then next slide. She did ultimately complain. This is about a year after her ILI, and now she's off immunotherapy. So this is about a year later. She had a lesion on her thigh that was kind of always present, but was becoming painful, and she would sit on it and it would bother her. So this was the lesion on her kind of lateral left thigh. It slightly increased on size on imaging, so we elected to go ahead and take it out for more palliative nature and symptomatic relief. This is about 6 years after her diagnosis now. And go ahead and advance the slide. And on that excision, more or less, she had what would be considered like almost a complete pathologic response. They found some very rare foci of residual melanoma, but they actually, in the comments section, they hedge a little bit about whether they were even really truly melanoma cells. But all of that whole area was really just dead previous melanoma. We can go to the next slide. So in this example, you kind of see a complete arc of care going from, all the different treatments we have, ending with another excision on her. She's still doing well. So she's almost 7 years out from her initial diagnosis and still quite functional.
That is awesome, Dr. Visioni. Combination of old treatments like ILI and modern treatments. I think it's important for anyone that sees in transit melanoma to have a lot of tools in the armamentarium. Just like you said, extremity versus truncal, the approach is going to be different. And I think you kind of nailed it. So thank you.
I appreciate it. Thank you, guys.
Dr. Tufaro, if you could you go through your case study very, very quickly?
Yes.
Maybe like
Yep,
4
very
minutes
quick.
max.
Yeah, this is a perfect example of the combination of surgical oncology and plastic surgery. This is a 16-year-old boy. Of course, his father is a professor of neurosurgery at the hospital I was working at, and he has a 1.7 millimeter thick melanoma on the helical rim. That was with a shave biopsy. So there's my planned resection, and you can see the 3 X's on the cheek are the sentinel lymph nodes and my planned incision. Next slide, please. So sentinel lymph nodes marked out, preauricular incision. As I said earlier, the approach to the sentinel nodes is going to be built into our reconstruction. Next slide, please. So here's our blue dyed sentinel lymph node elevating our soft tissue off the parotid capsule, and we'll take out the 3 lymph nodes through that one long incision, which will be well hidden even a young boy. Next slide, please. The problem is the ear. I won't go through all these, but next slide, please. So there's the dog bite out of the ear. We're going to reconstruct the ear at the expense of the lobule. So to really do this, you have to take the entire ear apart. Next slide, please. You see the marked out incisions. We take the cartilage off the dorsum of the ear, mobilize the skin, cut out the excess skin on the dorsal aspect of the ear. Next slide. This is him at about 2 weeks after surgery. He has an ear. We've reconstructed the ear at the expense of the lobule. We've taken out the cartilage. We try to minimize the cupping of the ear by taking out the cartilage. And I followed him for a few years. Then he went away to college. And his father kept in touch with me and said he was doing fine. But combination of resection and reconstruction through those incisions. I think that's it. Next slide. That's it.
All right, pretty amazing. Good stuff. Yeah, it's always good to see, especially we don't think about it, but melanoma can hit at any age, and so taking care of teenagers, and it's not unheard of. And it's yeah.
I just did a 22-year-old patient with the same melanoma in the same spot, a young lady.
Yep. Yep. My youngest patient, I think, was 12, and it was in the era of primitive immunotherapy with interferon, and so they're treated just like the adults. But again, great presentation, Dr. Schindorf. If you could do your case study in about 4 or 5 minutes.
There I am. I sure can. So my gentleman is a 58-year-old gentleman who had a history of a double kidney transplant in 2012. And he presented with a left upper extremity skin lesion that he had had for approximately 3 years. He had said that it started out as a small flat lesion and then became more nodular and grew significantly. And occasionally he would bump it and it would bleed. He went to dermatology and had it biopsied. It came back as a nodular melanoma that was at least 2.5 millimeters thick. It was ulcerated and was staged as a PT3B. So I took him to the operating room. I performed a wide local excision and sentinel lymph node biopsy. His pathology came back as an invasive nodular melanoma with some associated melanoma in situ. His final Breslow thickness was 4.5 millimeters. It was, again, ulcerated. His margins were negative, and his sentinel lymph nodes came back as 3 out of 3 being positive. So given his positive sentinel nodes, this would then stage him as a stage 3 and would qualify him for adjuvant immunotherapy. However, with his history of a kidney transplant, it was something that we had to balance, avoiding the transplant rejection as well as the progression of his disease. Given his stage 3, I did evaluate him for distant metastatic disease. His staging scans were all negative. And in hopes that maybe he had some other therapeutic options, we sent a BRAF mutation status, and he came back as wild type. So I presented him at the melanoma tumor board, and the consensus was to perform an axillary lymph node dissection in order to clear out as much microscopic disease as possible, in the hopes of increasing his disease-free survival and avoiding the need for any additional therapies. His pathology from that came back as all benign of his 15 remaining lymph nodes. I again presented him at tumor board, and the consensus was then to do adjuvant axillary radiation due to the fact that he had 3 positive axillary nodes. He tolerated this and is currently under surveillance without any evidence of recurrence or metastatic disease. And we thankfully have a great addition to our team who is an onconephrologist and has helped in decreasing his overall immunosuppression medications for his transplant while maintaining transplant viability, in the hopes that with a lessened immunosuppressive state, his natural immune system may be able to help do the melanoma surveillance and keep any recurrence at bay for as long as possible.
Right, that's a good case, Dr. Schindorf. I would say that each of the topics, especially yours, could be a whole day discussion, honestly. And the amount of patients that we see now that are immunosuppressed from different biologicals, for inflammatory bowel disease, rheumatoid arthritis, there are so many biologicals on the market. I recently had a patient that was on IL-17 antibody, and there's wasn't a clear association with true immunosuppression, but he developed 2 melanomas within the course of a year and a half. And so we're seeing this a lot. And, with the solid organ transplant patients, it can be a real problem. 10 years out from a solid organ transplant, all these patients are going to be at very high risk for cutaneous malignancies, and especially melanoma, which can behave very badly. So I don't see if there's any other questions from the audience. We have maybe 2 minutes. I don't know if there's any other topics that you guys want to bring up. Anything that you want to
I was going to bring
clarify?
up a point that you were talking about, Joseph. We're all seeing more and more immunocompromised patients, and the general public is getting swamped with advertisements of taking immunomodulators for everything from, psoriasis and eczema to rheumatoid arthritis and inflammatory bowel disease. And I don't think the general public understands what's happening. There's a huge increase. I've seen patients on these drugs with bad Merkel cells. They present to me with primary tumor, already have metastatic disease, melanoma, multiple sites. And I just don't think that the general public understands what's happening. And certainly the physicians that are ordering this don't seem to be educating these patients. And these patients are not getting enough surveillance that they need once they're on these drugs.
Right. No, I completely agree. I think most people thought that when they start going with specific antibodies to block specific pathways for different diseases like IL-17, IL-21, or IL-23 for psoriatic arthritis, that maybe there would be less global immunosuppression, but that does not seem to be the case. It still seems to be a big problem.
I think we're seeing an explosion of these cutaneous malignancies, and we're going to see more and more with the aging population as well.
Right. I agree.
I'll
So
add
I
to
want
that it's oh sorry, Joe, but I was just going to say I'll add to that it really requires us as physicians treating melanoma to understand these drugs and to kind of be able to incorporate that into their care. And melanoma is incredibly simple, except when it's not. And more and more these days, it is very much not. So yeah, it requires us to really do a lot of legwork as well.
Okay, so I really want to thank you guys. It was very informative. I let the audience know that you can reach out to us anytime if you had any questions specifically after this. And then just to wrap things up, CME credit claim. To receive your CME credit, please scan the QR code on your screen with your phone and follow the prompts. Credit claim details and presentation handouts will also be sent to all attendees later today. And then for our next live from Cleveland Clinic program, please join us on September 24th for Beyond the Plate, Modern Approaches to Nutrition Therapy. Thank you, everybody.